Hello, hi, I'm Dr. Mona from Malaysia.
Dr.
Hello.
Matthew, can you hear me? Is it
Hi,
okay?
from Vietnam.
Yes.
Hello, everyone.
Yeah.
So do we have Dr. Jalil or no? Hello.
Yes. Are you talking to me?
Dr. Sahab, I cannot see Dr. Jalil till now.
We cannot see Dr. Jalil. He's not here now, huh? So let's start. Yeah? Michelle is okay?
Yes, doctor, please.
So when Dr. Jalil join us, please let us know that maybe he wants to add something, okay?
Sure, Dr. Sahab.
Thank you. So hello, Aisha. Hello, good morning. So good morning, everyone. And a very warm welcome to all our colleagues joining us from across the Asia and beyond. It is my great pleasure and honor to welcome you to today's Asian Paralympic Committee webinar on injury prevention and sports medicine. It's been a long time, nearly 1 year from our last webinar series. And that's a very, very hot spot for me, that in kind of lightning that you all are here from all of Asia. Thank you for you from the side of Asian Paralympic Committee. Our friends and colleagues work hard in 7 days to prepare this magnificent job. So my name is Shahab, and I'm the moderator of this webinar working with you guys. So I have the pleasure of serving you as the moderator of the session. First of all, I would like to sincerely thank the Asian Paralympic Committee, all the secretariat, and the people who are working with us for organizing this important educational webinar. And I would also like to thank all of you for taking time to joining us despite your busy schedule. I know all of you are very busy for the Nagoya, and these Nagoya games are getting a long time and make you busy. But thank you for joining this session, and I want to thank the Dr. Jalil, Dr. Kupaizadeh, who is the president of the MSSC, and he will join us, I think, in the middle of the job to have his ideas too. So I think if we don't have Dr. Jalil, it is better to go directly to the session, and to do so, I think it is nice to have Dr. Matthew to start the job. So Dr. Matthew, he is very famous in the job of the medical sessions and these things. So he's a veteran international athlete. He is a surgeon and trauma and emergency physician by profession. For over a decade, he served as chief medical officer for major international Olympic Games, Commonwealth Games, and Asian Games. Currently, he chairs the APC MSSC medical subcommittees, working and helping us in the anti-doping subcommittee, and serve as a global ATLS instructor for the American College of session. And today we have him for this very important webinar. We are very fortunate to have with this today an excellent expert in this field, I think, and this is the Dr. Aaron Basil Matthew, to share the knowledge and experience. So Dr. Matthew, thank you for joining us today, for sharing your expertise.
Thank you, my
So,
brother
Dr.
Shahab.
Matthew, thank you. Dr.
Thank you.
Matthew, thank you for joining us. Do you have me?
Yes, I can hear you. Am I audible to everyone?
Yeah, thank you for sharing with the APC committee. Before we begin with Dr. Matthew, I want to just say that please keep the microphone muted during the presentation, and feel free to use the chat box to share the question. Let's go to Dr. Matthew. We are all ears, Dr. Matthew.
Thank you so much, my brother Shahab. It's been a pleasure coming back again for the wonderful seminar presentation, the drive which we have started from last year. A lot of presentations we had done. I would take this opportunity to thank everyone from APC. My special regards and thanks to Professor Jalil, to you, Dr. Shahab, to all the APC Secretariat, Michelle, Ubaid, everyone. All right, before going into the seminar proper, I would just like to, Michelle, are you there with the slides? All right, so today we will be discussing about the common injuries that's happening, that's very usual in para sports. But before going into the topic, I just wanted to see, now this topic is more of like a medical topic. I'll be discussing some of the common injuries which are happening in para sports across the globe. But more than going into the, I know that the crowd right now is a mix of everyone, a mix of athletes, mix of physiotherapists, team doctors, everyone is there. So it's more about the emotion behind this seminar. The emotion is to use your common sense while dealing with all these situations and do the appropriate thing rather than knowing deep about these medical conditions. It's well and good. I mean, if you know deep about all these medical conditions, it's good. Being a medical professional, if you are a team doctor, you should know all these things. But it's for the athletes and for the athlete support personals. If you just know the basics and if you use your common sense, some of the life-threatening issues can be prevented and can be saved. So that is the whole purpose of this seminar, to just to know, just to be aware about these injuries and take it from there. I always tell the athletes or the athlete support personals before going for any games, there are three most important things, 3-step game time check. This is what I usually say. First thing is, like, whenever you are in a games zone or a games arena, always be aware about some of the medical emergencies, some of the life-threatening emergencies, which all of you should know. The most important, okay, if you have some trauma, if you have some injuries, yeah, definitely spinal cord injuries, concussion, head injuries, these are all deadly, these are all life-threatening. Especially when it comes to para sports, another important topic is autonomic dysreflexia. Most of you guys will be aware. I will discuss about AD in the coming slides. Then exertional hyperthermia. These are some of the life-threatening conditions which all of you should be aware, especially you are belonging to the para sports family. Always before getting into an injury, use your common sense. Before going into each part of the muscle or joint or anything, just check the equipment. Never treat a muscle or joint strain in isolation. Always inspect the wheelchair or the prosthetic socket or the straps or the orthosis. Most of the times there will be a quick fix there. Then the third thing is like a functional transfer test. See, most of the athletes are wheelchair bound or some disability will be there. So evaluate that whether the athlete can independently transfer himself or herself in and out of the wheelchair or equipment without any sharp pain. That itself says that, okay, it is not like a life-threatening situation. Most of the times this can just be managed because he is able to ambulate by himself. Anyways, these are some of the three, the 3-step quick checking to rule out any medical emergencies, to check the equipments, to see the functional mobility, the functional transfer of the guest. If you know the basics, then most of the times you can save time and you can prevent a life-threatening complications. Okay, next slide, please, Michelle. All right. So this is just an epidemiology or a unique biomechanical demands. See, the incidence and prevalence of musculoskeletal injuries in para-athletes has reached 40% with an incidence rate of 10 to 14.3 injuries per 100 athlete years. What we usually see in non-ambulant, in wheelchair athletes, the injury is predominantly upper limb. That is the shoulder girdle, elbow, wrist. And those who are able to move, the ambulant para-athletes, they suffer lower extremity injuries, which is more than 65%. This is a rough estimate. For those who are non-ambulant, the upper limb, the whole body, the upper torso has two distinct roles. I mean, not only for the games perspective, but for the daily functional mobility, like transfer, like wheeling, dressing. So an upper extremity injury can severely impact their daily independence alongside with the sports participation. Next slide, please. All right. So now what I'm going to do is I'll be discussing 20 different cases. Most of these cases are very medical oriented, but just pay attention so that at least if you can understand what is happening, that is more than enough from this seminar. It's not that you have to go deep into these technical terms and stuff like that, but just get an overview of what's happening, and you should have that knowledge to know what to do and what not to do. That is the whole purpose of this seminar. So going to our first case, that is rotator cuff tendinopathies and subacromial impingement. These are very common in wheelchair racing and marathon T54. Usually the usual presentation is like a young male racer presenting with a progressive anterolateral right shoulder pain during the push phase. See, there will be a shoulder pain which happens because of this forceful internal rotation and abduction and the full extension. So when you do this repeated motion, there is a muscle, supraspinatus. That muscle can get trapped. So there is a compression of the supraspinatus tendon and the subacromial bursa here. It can lead to chronic injuries and pain and tendinopathies. So as a athlete support personnel, what is your thought process? See, when you have an athlete who is complaining of shoulder pain, first thing you can do some simple test. We call it with different names: positive NIR test, Hawkins-Kennedy test, MT-CAN test. But these are, nowadays we have a lot of facilities available, Google, ChatGPT or whatever. You can just, if somebody is telling you about a shoulder pain, you can perform this simple test. Like the MT-CAN test is just like you keep your arms like this and give resistance. So there will be intense pain here. Okay, that means that the supraspinatus tendon is compromised. What are you going to do? Again, it's just the basic rest. Rest gives ice. We have the protocol which you all should know. We call it RICE. RICE is rest, ice, compression, and elevation. This is like a blanket term for most of the sports injuries. So give rest to the joint, apply some cold or cryotherapy. Okay, in competition, it is not allowed to have a corticosteroid injection. But out of the competition, if you are not in an international event, you can, for early healing, get a proper medical attention and do the injections or whatever. Again, this is for the physio. You have to focus on this rotator cuff strengthening exercises and scapular stabilization. And also there is a muscle called pectoralis minor in the chest. Sometimes that muscle gets tightened, so it will pull the shoulder like inwards. So if you release the pectoralis minor, most of the times it also will give much relief in pain. You can also, physios can do the taping, the kinesiology taping, and so that the humeral head is displays backwards and downwards. So the red flags in these type of cases, especially when the athlete complain of difficulty to raise the shoulder, okay, and night pain, severe pain during the night, during the sleep, and pain during their normal motion, normal routine wheelchair transfers. You should pay attention, check for these signs, and give the correct treatment. Give rest, stick to the basics. RICE is the common for everything: rest, ice, compression, elevation. This is the standard. Coming to the second case, it's like a very common in wheelchair basketball, because in this case there is a 31-year-old female reporting with bilateral hand numbness. Why this hand numbness is happening? I mean, the hand numbness, especially 1 to 3rd digits in the right hand, 4 to 5th digits in the left hand, nocturnal awakening and loss of the pass control. This happens because of the continuous motion against the push rims and the hand rim breaking. That gives extra compression to the wrist and to this area. See, actually in this portion, there is a retinaculum. There is a sheath. For easy understanding, there is a sheath. We call it flexor retinaculum. So when there is inflammation in this retinaculum, what happens is that there will be a compression of a nerve passing under the flexor retinaculum. We call it median nerve. If the median nerve is affected, the medial 3.5 fingers will be numb, will be painful, lot of discomfort. There is another nerve which is called ulnar nerve. There is a canal here which is called Guyan canal. Again, the same thing, because of the stress, repetitive hypothenar impact, they also will present with nerve compression symptoms. For the physios and for the team doctors, you might have heard, or you already know about these tests: Fanel's test, Tinel's test, Tinel sign. Like, do this extensive, flexion. You can do like this and wait for 30 seconds. There will be numbness, there will be pain. That means that the flexor retinaculum is inflamed. So even for athletes, you can just check, like if you do this hyperflexion of your wrist, if you are feeling some pain, yeah, there is some problem for your median nerve. Or you can do some tapping over this area if you are feeling some pins and needle sensation. That means you are having some compromise in your median nerve and ulnar nerve. Advanced studies, nerve conduction studies can be done, but again, the management is like, give rest first. If you're out of competition, try for some ultrasound guided steroid injection. If the lesions are more advanced, then you have to go for a surgical release of the flexor retinaculum, carpal tunnel release you have to do. Again, for the physios, you can also plan for this wrist splinting in the night, nocturnal splinting in the night. Also teach the athletes some nerve gliding exercises and this flexor retinaculum mobilization. Most of the times, if you see, it is related to the equipment. So try to provide some good palmar gel cutouts over the thumb and the pinky fats to offload this area, complete offloading of that portion. Also give a customized gloves to them, and switch to a ergonomically feasible, a good push rim to distribute the pressure among a wider surface, rather than giving a small area to push. So some of the red flags: persistent numbness, pain, discomfort, pins and needle sensation, muscle wasting, especially in this area. The muscle is, if it is wasting of the muscle, if the muscle is loose, that means there is problem for your nerves. So you need to address it. So physios, team doctors, and even athletes, pay attention. And if you have these complaints, get a proper medical attention. All right, next slide, please, Michelle. Yes, this is one of the hot topics, especially when it comes to wheelchair athletes. Most common in wheelchair rugby, Here an example of a 28-year-old male C6 athletes presenting with severe pounding headache, diaphoresis. Diaphoresis means sweating, above C6, facial flushing, nasal congestion, and blood pressure. Why this topic is important? I will just discuss this topic in simple terms. What happens is that, okay, when there is when you have an injury from T6 and above, and you have obviously when there is some pressure inside your, I mean below T6, it could be somewhere in the bladder, it could be in the bowel. If your bladder is full, if your bowel is full, or I mean if you are giving some noxious stimuli below the injury level, this will trigger some sympathetic discharge. Sympathetic discharge means all the hormones in the body like adrenaline, noradrenaline, this will be stimulated. It will give sudden increase in cardiac output. Your heart rate will be more, your blood pressure will be more. When this sympathetic stimulation is there, it will lead to vasoconstriction, severe vasoconstriction. Vasoconstriction means the blood vessels will compress so that the blood pressure will be too high. Automatically, there is a mechanism in our body to control this blood pressure. We call it parasympathetic response. The parasympathetic response is from the carotid arch, from the aorta, from the brain. This leaves parasympathetic will try to control the heart rate, control the blood pressure. But what happens because of the spinal cord lesion, it is not passing down. So in the upper body, there will be decreased heart rate, but the lower body is still in high blood pressure, vasoconstricted. So the point is that the patient will present with upper body, there will be severe flushing, sweating, vasodilatation. There will be nasal congestion. Blood pressure will be above 160. It will be like 200, 210. And peripheries will be cold, like pale, clammy, with vasoconstriction. This is typical of AD. Now, why AD is a hot topic? Because athletes can induce AD to get some extra benefit in your performance. That's why IPC and World Anti-Doping Agency has prohibited this thing and prohibited this, and it come under anti-doping rule violation. And how athletes do that? Some people, I mean, even the coaches also tell them to do this type of this comes under anti-doping. They can just clamp your catheter so that your bladder will be full and the bladder will be distended and the sympathetic response and the same thing will happen. You can also give some tight strapping so that the sympathetic response will be more. So that's the reason why before going for these games, there will be a random checking by all the team, the officials there. If your blood pressure is more than 160, you will be given a 10 minutes rest. Then they will check it again. If it is still above 160, they will leave you from that games. If they find that you have done some manipulation, you will be out of the games because it comes under anti-doping rule violation. But what if it is like if it is it's not an intentional thing, it just happened like that? How to manage this is very important for your physios, for your team coaches, the support staff. Whenever you see a patient who is having severe flushing, sweating, high blood pressure above 160, try to check everything. First thing is sit the athlete 100% upright, straight. Don't lie them down because it can lead to stroke. It can lead to cardiac arrhythmias. They can die in front of you because the blood pressure is more than 200. It can end up in intracranial bleed. So always sit up the athletes. That's the first thing. Then check everything. Loosen all the constrictions. If there is any abdominal binder, any leg straps, any chest harness, any shoes, any tight shoes, remove everything. Check the urinary catheter. If there is any king, sometimes it can be a king. King means a slight turn, or most of the time, 80-90% of the time, it is overfilling of the bladder. So catheterize, and if there is no catheter, you catheterize so the bladder stimulus will be gone and it will be back. If the BP is still, if the blood pressure after doing all the maneuvers, if it is still above 160 or 180, then we can give some sodium nitroprusside or some captopril. These are some of the medical options, but in games, they will give you 10 minutes, 15 minutes rest to get recovery. If it is not recovering, then they will leave you from that. So this is a anti-doping rule violation. So make sure that you don't have all these problems. You don't end up in a AD during these games. It is very, very important topic. And when you do it by yourself or with somebody's help, it is called boosting. Boosting is prohibited in the games. Next slide, please. All right. So now coming to this pressure injuries. Pressure injuries are very common in wheelchair athletes. 24-year-old female athlete, complete L1 paraplegia, presenting with a non-blanchable skin breakdown. Yes, when you lose that protective sensation below L1, that prevents that normal discomfort perception. When you have some discomfort after sitting for a long time, you will feel some discomfort, right? But when you lose that sensation, you are not feeling it and you continue to sit there for a long time, there is more moisture accumulation, there is more friction, it leads to an ulcer. So always check your body. If you are sitting there for a long time without movement, then you need to find out, I mean, if there is any non-blanchable skin lesions. If you see something, always offload your weight. Zero weight tolerance over the ulcer area till it heals, till it reepithelize. That is one of the protocol. And again, if it is an ulcer, wound care management. If it is infected, you have to give some antibiotic. Otherwise, give some hydrocolloid dressing, some foam dressing. Nowadays, we have this wheelchair air cell cushions, Roho cushions. So try that. And also, physios, you should ensure the athletes do the weight shift protocol. 30 seconds lean forward, 30 seconds, press every 15 minutes, change the position. And with a mirror assisted skin inspections can also help. All right, so coming to the next slide. Yes. This is spine overuse, especially for seated para athletes when they do this high intensity sports like javelin, shot put, discus, because see, their body, the lower torso is in a stationary position, but they are doing sudden thrusting movements, and this can complain of acute lower back pain with flank muscle spasm and the back facet joint tenderness post-competition. This usually happens because of a rigid pelvic strapping, and throwing frame prevent this so-called kinetic chain force dissipation to the lower limbs. This happens because of the explosive this rotational torque and the other forces, the acceleration, the deceleration forces, which is completely absorbed by the lumbar spine. That's the reason why this happens. Again, the same management: rest, apply some cold warm gels to reduce the muscle spasm, followed by you can apply cold or cryotherapy, and muscle releasing by the physios. They can try this QL, quadratus lumborum muscle release, and NSAIDs for the pain relief. Again, always make sure that the equipment is adjusted. So throwing you adjust your throwing frame. That tilt should be adjusted maybe 5 to 10 degree. That can prevent this type of injuries happening. And also modify the strapping angles so that the shear force is distributed evenly. Okay, coming to the next is next topic is inversion angle injuries, the ankle sprain. It's very common in para sports. Most common in visually impaired sprinters, because the usual for them, the reliance is more on the feet forward. The guide runner cues. They depend on the guide runner cues And if there is some guide misalignment it can lead to unexpected inversion of the foot and lead to this sprain. Again, as I told in the beginning, the protocol is universal, that is RICE protocol. RICE is rest, ice, compression, elevation. But nowadays, the new concept is, we call it POLICE. POLICE is protect, and that O and L is for optimal loading. Then I for ice, C for compression, E for elevation. So this is how you have to manage an ankle sprain, or a ankle sprain can be like type 1, type 2, type 3, based on the ligament, how much injury has happened. So always you can, especially for the team doctors, you should know about the ankle rules, Ottawa ankle rules. Like you have to check for the pain, especially in the medial side, in the lateral 6 centimeters, in the midfoot. If there is tenderness, you have to get an X-ray and rule out any fracture. Otherwise, POLICE, everyone should know, even the athlete should know, POLICE, protect, give rest, optimal loading. That means you don't have to take rest for a long time. Start your recovery, start your rehab, start your physio at an early stage, so that it will enhance your recovery. So you all should know how to plan your rehab in case if you had these type of injuries. All right, next slide, please. Okay, the next is another hot topic, that is exertional hyperthermia. We discussed about AD, autonomic dysreflexia, but this is very similar but slightly different manifestation, and it is also a life-threatening emergency. 33-year-old male athlete with a C7 incomplete tetraplegia, usually sudden collapse with delirium. Delirium means is saying something, which is not in sense, with extremely hot skin. And the core temperature, when you check, it will be more than 40. Why this happens? Because their control of sweating and this cutaneous vasodilatation is lost. So they are not going to sweat. Even when the temperature is more, the body temperature, the body get more heat up, but they cannot sweat and control the temperature. So this leads to intense heat and they cannot sweat. See, in autonomic dysreflexia, there was bradycardia. Heart rate is less because of the parasympathetic. Here, the heart rate will be more. Blood pressure will be more, but not as much as like AD. So this is how you have to differentiate between AD and exertional hyperthermia. AD will be having a lot of sweating. Blood pressure will be more than 200 or 160. Exertional hyperthermia, there is no sweating, but with a lot of heat. Blood pressure will be not that much high, but it can still be elevated. Team assistants, athlete support personnel should know how to manage AD and exertional hyperthermia. In exertional hyperthermia, if you see an exertional hyperthermia, immediately relocate to a cool, shady place. Start active cooling. You can continue this misting or fan. Place ice packs over the body, over the neck, over the axilla, over the heated areas, over the axilla, or the groin, in the necks. Give something to drink, good hydration. If it is too much, you can start IV fluid. If it is a life-threatening condition, the doctors have to start IV fluid. If the mental status, because the doctors have a specific way to assess everything, the neurological insult. So if it is not, the mental status is not coming back, and if is in a life-threatening situation, we have to transfer to a hospital. Don't waste time, because these type of cases are an emergency. So the coaches and the athlete support personnel should know when to take a decision and what to do in this type of situation. Always I tell the coaches, if there is a chance of getting hypothermia, use this pre-cooling before the games. Do the pre-cooling ice vest for 20 to 30 minutes before the games, before the warm-up, and then monitor for these type of situations. All right, so the next case is a UTI, neurogenic UTI, and see, UTI means urinary tract infection. This is very typical because suddenly I've seen many athletes. I mean, all of a sudden there is a 10 to 15% drop in their PR, personal best. I mean, especially in para powerlifters, 15% drop in their bench press power. So most of the time we will not think about a urinary tract infection. So always make sure that if the urine is dark in color, it is cloudy, and the athlete is having dehydration, muscle cramps, suprapubic, I mean lower abdominal pain, low into groin pain, flank pain, always suspect urinary tract infection or bladder calculi, stones. If the urinary tract infection is there, then you have to get a culture and treat with appropriate antibiotics. Next slide, please. Yes, this is the residual limb pistoning and friction blisters and folliculitis. Usually with athletics, para-athletics, T63, transfemoral blade runners, very common. 25-year-old male sprinter using a carbon fiber running blade presenting with distal limb pain, friction blisters, skin erosions, purulent folliculitis. So what usually happens is that the running blade generate high vertical impact force. So when the stump volume is inadequate, or there is like the gel liners are worn off, it can lead to pistoning. Pistoning means that vertical displacement inside the socket. It can lead to infection, so you have to check for the sockets, check whether the pistoning is happening. Offload, complete offload, give rest to that joint, and then if there is any infection, you have to give antibiotics for that. So all the coaches always pay attention if the athlete is complaining of some pain, discomfort, if there is any skin changes, pay attention and treat it, get your medical help and treat it accordingly. Next topic, next slide, please. All right, this is another very important, very important hot topic, concussion. All of you guys, athletes, athlete support personals, coaches, physios, everyone should know what are the features of concussion. Usually it happens with wheelchair rugby or para ice hockey. They present with, I mean, sudden collapse. We call it whiplash when the neck moves like this, sudden movement, or when you have a sudden hit on your head, it can lead to concussion. These are all basics. First is you have to see what is the problem. If the athlete is complaining of, I mean, we call it look, listen, and feel. See, when they complain of some severe, intense headache, don't see, these are the warning signs before going into a severe problem. So the warning signs need not be ignored. Always make sure that if they are complaining of these warning signs like headache, loss of consciousness, blackouts, nausea, vomiting, and they are feeling intense neck pain, don't ignore these. These could be signs of concussion. And how to manage? I mean, see, if there is any intense neck pain, always, especially when it comes to ATLS or in trauma, this C-spine immobilization is of paramount importance. If you can maintain the C-spine stability, if the C-spine is immobilized correctly, then you are preventing a life-threatening emergency. In para sports, we have a way how to find out if there is any concussion. We call that testing at SCAT6 testing. Most of the doctors and the physio, they are aware of this. Sport concussion assessment tool 6. There are, I mean, it's very elaborate topic. I don't want to go deep, but some of the on field, you should know how to do the SCAT6 testing. Check for the red flag signs, which I already mentioned, like headache, loss of consciousness, vomiting, nausea, intense neck pain, any blackout. And check for the GCS. I hope you know about the GCS, the Glasgow Coma Scale. So the eye movement, the verbal response, the motor response. Then off field, you have to ask some questions. I mean, you can check. You ask simple question like, where are you right now? What is the time? What is the date? These are some simple questions. If the athlete can answer, that means the neurological is okay. So do the simple testing. Then as a trained doctor, you have to check for the motor examination, look for the power, look for the tone, look for the sensation, look for the reflexes. See, for a medical doctor, you can do all these testing and find out if there is any concussion. And if you are suspecting concussion, without any time delay, immediately transfer the athlete to the hospital. Don't waste your time because it can lead to a death or a fatal emergency. So early testing, early identification of these things are of paramount importance. All right. So next topic. All right. Coming to upper extremity traumatic and overuse pathologies. Next slide, please. Yes. This is another common thing which usually happen for wheelchair basketball. When there is a sudden collapse, you can see that there will be an acute shoulder pain, there will be a tenderness, a pain, and a step of deformity in the shoulder joint. So this usually happens because the acromion, this shoulder joint is comprised of this clavicle, scapula. There is acromion, coracoid process. So these are like technical terms, not but the doctors will know. So it happens due to the disruption of some ligaments in the, we call it acromioclavicular ligament and coracoclavicular ligaments. Again, if you find out these type of injuries, give rest, give some sling. You can also do this figure of 8 wrapping, give cryotherapy. Just again, the police and the RICE should be, you all should know what is police and RICE. Then you have to immobilize the collarbone, and later on start with physio, start with rotator cuff strengthening exercises, push rim loading, scapular strengthening, isometric scapular control. Again, always check the equipment. If there is anything you can do in the equipment to adjust the armrest height, something you can do so that this also can prevent this type of injuries. Because if you increase the armrest height, it will prevent the gravity from pulling down on the shoulder joint. So simple fixes, but it can change the entire game. All right, coming to another important topic is the distal radius and scaphoid fractures. Radius is the bone here, radius, this bone, and scaphoid is a bone in this portion. Usually these type of injuries happen with wheelchair tennis, wheelchair fencing. The athlete present with, what happens is whenever there is a chair tip over, they fell down from the chair and fall on an outstretched hand. We call it fush injuries, because the hand will strike like this to the ground and will end up in fracture. So why this fracture is very important? Scaphoid is one of the carpal bones. It is common for, because the blood supply to that bone is very limited. So if you are not identifying this problem, it can lead to a vascular necrosis, that it can lead to permanent damage of that joint. That's why it is very important to find out. How you can find out? Simple. You can just do a pressing of the anatomical snuff box. This is the triangle area in this portion where you can simply push and see if there is any tenderness. If they say tenderness, okay, get an X-ray and rule out scaphoid fracture. If there is scaphoid fracture, team doctors, you have to put a thumb spica splint, and again the police protocol to be followed. So anatomical snuff box, doctors should know where to check for a scaphoid fractures, or physio also should know. If you suspect this type of injuries, immediately get an X-ray and fix it. All right, next slide. Yes, this is the slap lesions, very common in swimming, paraswimmers. They present because of this repeated this catch phase. They present with this deep shoulder pain. what happens is that the SLAP means superior glenoid labrum from anterior to posterior. SLAP, superior labrum, anterior to posterior lesion. Basically, I mean, for layman, it's like a pain in the shoulder. It happens because of this traction, this pull for the long head of the biceps, which is attached to the shoulder joint. Again, if you have repeated shoulder pain, repeated shoulder discomfort, get an MRI to see or to rule out a SLAP lesion. If SLAP lesions are identified for physio, you can do the biceps offloading, taping, then again rotator cuff strengthening exercise, scapular dyskinesia corrections, and all the other techniques. And swimmers should try to shorten the catch phase to reduce this. This happens because of deep internal rotation. So you can modify your technique. Coaches should tell the athletes to modify their techniques if they have these SLAP injuries. If it is a very severe SLAP injury, then you have to go for surgery. All right, next slide, please. Okay, this is amputee specific and neurological complexities. We will be discussing about phantom limb. Next slide, please. Yes, phantom limb. What is phantom limb? Most of you guys who are amputee will be knowing about this phantom limb. 34-year-old cyclist reporting of severe burn and electric shock pain in the non-existing foot during hard pedaling. That means there is no limb, but he's feeling pain there. This is like a very peculiar type of problem. That's why it is called phantom limb, because the limb is not there, but he's feeling the pain there. It happens because the limb is already cut off. There is some nerves which form into a neuroma, which is sending some signals. And when the socket pressure, you'll be having a socket and the socket pressure is more, and the neuroma is there, combined with this central cortical reorganization, because in the brain also these nerve stimuli are perceived in a different way. This lead to phantom limb pain. How to manage? See, it's like a psychological thing. So we usually advise the athletes to go for a mirror therapy, to stand in between, place a mirror in between their limbs and see that they are not having a limb in that side, and check for the normal side and move that side and look at the mirror and see if it is moving. It's like a psychological training. This is called mirror therapy. So physio and coaches should know how to give a mirror therapy. For the doctors, you can try some nerve stimulations, transcutaneous nerve stimulation. You try some medications like gabapentin, pregabalin. These are some of the pain medications for neuropathic pain. If it is still not getting better, then there are surgical options. TMR, that is this targeted muscle reinnervation. Surgeries can be done. This is how it should be managed. Coming to cerebral palsy, muscle hypertonia, adductor strain and hip subluxation. See, this usually happens in para football when athletes with spastic diplegia complaining of groin pain with increased, they already have a scissoring gait, but they will have increased in that scissoring gait. This happens because the adductors are virally contracting, abductors are weak. Abductor means it's like this, adductor means it like this. So it is like a crossed leg. Okay, this is what happens. So what we can do here, again, there are medical options of giving some botulinum toxins to release the adductor muscle so that it is coming back. Give physiotherapy, again, some stretching exercise. Physio should know how to give, but avoid quick stretches, slow, passive adductor stretching. Then strengthening exercise, gluteus medius strengthening exercise, abductor strengthening exercise. So that's how it should be managed. Next case. All right, so now coming to bursitis, very common in wheelchair racing because of the more movement in the elbow joint. So they will present with a fluid-filled swelling posteriorly in this area. where the triceps is inserted. Again, this happened because of the push rim propulsion. There is violent elbow extension. So that's why this happens, because of the micro trauma. Again, if the treatment is just the same, start with police protocol, the RICE protocol, give some ice therapy. If the bursa is too much filled with fluids, then we have to aspirate. And always make sure that get some good gel padding where the elbow strikes. This is for the coaches. They have to inspect the wheelchair to see if the wheelchair equipment is correctly placed. And again, for the coaches, you can tell them to adjust the stroke mechanics. So don't always go for the full, the hyperextension. Don't go for the lock-in. Just leave it before the lock. So these are some of the minor corrections you can do so that you can avoid bursitis. If it is getting infected, it can lead to septic arthritis, which is an emergency. You have to treat with antibiotics. Otherwise, supportive management will be okay. If you are suspecting some serious issue, how you are suspecting. If there is increase in temperature, if there is severe pain when you touch, local warmth, local redness. If you think that it is more, always get a medical attention so that you can treat effectively. Joint aspiration, good antibiotics will take care of this problem. Then hamstring strain, very common in single leg amputees for the high jumpers, long jumpers, sprinters. This happens because, see, the one limb is not there, the other limb will try to compensate. So there can be some injuries to the biceps femoris tendon in the hamstring. Again, the same management, apply the police protocol. You all know police, protect, offload, optimal loading, ice, compression, elevation. Then there are physios. You should know about the strengthening exercises, the Nordic hamstring exercises, the pelvic leveling exercise. These all you should teach the athlete to do, and check the equipments timely so that there is no issues with that. Next case. All right, coming to decurrence tenosynovitis. This is another important topic, very common in hand cycling because of your wrist movement. There is a, as I told about the sheath here, there is another sheath in the back of your wrist. We call it extensor retinaculum. When the extensor retinaculum is inflamed, there are two wires, two tendons, which is going beneath the extensor retinaculum. We call it APL. APL is abductor pollicis longus and extensor pollicis brevis. It's technical terms, but two rods, two sheets or two wires are there under this sheath. Too much of movement of the wrist can lead to problems there. It can lead to decurrence tenosynovitis. That simple terms, there is swelling in the wrist, too much of pain, cannot move the wrist. What is the test? Coaches, your physio, they should know how to test. Simple test. Keep your arms, the thumb like this. Keep like this and do a simple stretching and extension. You can feel intense pain in the wrist area. This is how you are going to test for tenosynovitis. If you are suspecting tenosynovitis, then you have to again do the basic thing. If it is still not getting better, you have to go for a thumb spica splinting. Doctor should know. You can also try the kinesiology taping, ultrasound guided injections, steroid injections, not during the games, off games. And if it is still not getting better, then you have to go for a surgery. All right. Another important topic is patellofemoral pain syndrome. This happens especially in those who are using ankle foot orthosis, AFOs. And the typical sign is theater sign. It is called movie theater sign. Why? Because when you sit and watch a movie for a long time, then you feel pain in your knee. So that is patellofemoral pain syndrome. It happens why? Because the vastus medialis, the vastus medialis is a thigh muscle which is getting weakened. So the thigh, the femur is rotated laterally. The weak hip adductors that cause the femur to tilt under the patella, and along with a weak vastus medialis muscle, it will pull the patella laterally. So there is a displacement of patella and the femur. So there is pain which is forming in the knee joint underneath the patella. Again, physio, you should plan for, initial management is non-weight bearing. Then later on, plan for physio and exercises. The taping also will help. Abductor strengthening can help. Okay, then the last case to discuss is sublesional osteoporosis. This is like very common in chronic spinal cord injuries, spina bifida. 30-year-old T10 spinal cord injury athlete presenting with distal femur swelling with warmth and aching. Why this happened? Because sudden spinal cord injury, there is a lot of osteoclast. Osteoclast means it is absorbing the calcium and the bone forming substance in the body. So you will lose the mineral bone density 12 months or 24 months post the spinal cord injury. Your femur bone, your tibia will become very weak and fragile and leading to injuries and fractures. Immediate care is immobilize the limb. If you are suspecting, if you are seeing that, if there is some redness, if there is some swelling, pain, immobilize the rest, offload, give full rest to the joint. Give a good well padded splint, and then perform x-rays, DEXA scans, and then do the correct surgical fixation or non-orthopedic fixations if it is possible. Again, for the bone health, you can take bisphosphonate, vitamin D3, calcium. These are required, but always under a medical supervision. Don't take it just like over the counter. Don't do that. All right. So these are some of the cases which I wanted to discuss. But again, always before the games. Now we are going for the Nagoya Games. We'll be having a lot of fun there. But for all these, for all athletes, coaches, and everybody here, always before the match, 30 minutes before the match, inspect the skin over the bony prominence. Because see, when you go for one competition, if you are not paying attention, you will end up in more problems. So pre-match, at least 30 minutes before, try to inspect the skin over the bony prominence, the stump sockets. Ensure that the bladder is fully drained, bowel is fully empty. Unload your bowel, your bladder, and prevent AD. If you are suspecting there is a chance for exertional hypothermia, pre-cooling vest before the warm-up. If it is a warm weather, do that. Prevent AD crisis, prevent this heat stroke, exertional hypothermia, skin breakdown. In match, in between the match, spray this cold water, the cold water mist, and do some fanning. This will control the temperature. Good hydration in between drink, and check the glove padding and the wheelchair harness, the straps. Always have a look at all these things, because it can and prevent all this nerve compression, which is actually avoidable if you pay attention. Immediately post match, the first initial 0 to 30 minutes, always try some skin audits. Again, check if the skin is intact, perform cryotherapy or cold therapy if it is required. If the limb is having some compromise, some suspecting, doubting of the sprain, then do whatever which is correct at that point. And in the night time, if it is required, give some night wrist splints if you are suspecting some median nerve, ulnar nerve, or this decurvence, tenosynovitis. Wheelchair cushion, this Roho cushion inflation pressure, you can check, adjust the socket. This is how you have to plan your games. It's not like you just go there and do your things and come back. No. Before match, during the match, post match, and in the night. Especially during all these days, you have to pay attention to all these injuries. If you pay attention, you can prevent all these injuries. Next slide. Yeah, this we have already discussed. Next slide. Yeah, this is just a gist of all the cases which we have already discussed. Next one. Next one. Yeah. This also, again, I have discussed sideline triage. Always, these are the medical emergencies, top medical emergency in para sports. AD, autonomic dysreflexia, exertional hyperthermia, heat stroke, concussion, C-spine injury. So if it is AD, you all should know, first thing is sit straight. Make the athlete to sit straight, check the BP. If the BP is not getting better, you have to manage that. Remove all the noxious stimuli. Check the bladder, bowel, check the catheter, check the strapping. If it is hypothermia, intense cooling, C-spine. If there is any trauma, C-spine mobilization. Doctor should know ATLS protocols. Then the RICE protocol, the police protocol, you all know by now. Always inspect the skin. Or if concussion is suspected, then GCS, the SCAT-6 testing. See, okay, I have discussed a lot of medical things, but after all, it comes down to just common sense. Just look and see what's happening and use your common sense. That's all. It's not about big things. Okay, I talked about decurvent stenosynovitis. It's nothing like that. There is pain in your wrist. That's all. You don't have to know about decurvent stenosynovitis, median nerve, ulnar nerve. If you have pain in your joint, see how the pain happened. If it is due to some external factors, fix the external factors. If there is something you can do to prevent progression of this, do it. That's all. Don't worry about all these terms, but pay attention to these simple things. Then you will be fine. I think that's the last slide of our presentation. Now, if you have some questions, you are open, you are free to ask. It's almost the correct time, 1 hour. Thank you so much for all the patient listening. Over to you, Shahab.
Thank you, Dr. Matthew. Thank you very much for the excellent and very informative presentation that you have. I believe this information you have shared today will be extremely valuable for physician, physiotherapists, medical person, coaches, and everyone involved in the sporting para athletes. Now we will move to the Q&A session, and you can ask questions, guys, and you can write your questions in the chat box. Don't forget that if you want to have the certificate of this webinar, in the chat box, our friends from Asia, the APC, will write a link, and if you proceed the link, you can get answer some questions after the webinar, of course, and you can have the certificate. So up to you if you want to ask any question. And if Dr. Jalil is here, because he has some very so much technical problems connecting to the Zoom, because in Iran we have to have the VPN. So if Dr. Jalil is here, we are all ears to have Dr. Jalil too. If no, let's go to the question and answers. Dr. Matthew.
I've seen one question here. Can I get some enlightenment on the police protocol? From Edward. Yeah. Police protocol, see, these are all technicalities. You don't have to worry about the police protocol or the RICE protocol. It's just, again, simple thing. Okay, police means protect. Okay, first I will discuss about the RICE protocol. RICE is rest, I for ice, C for compression, E for elevation. If you have a joint sprain, if you have a ligament injury, first is rest, then ice application, compression by giving some compression bandage, and elevate. This was the old protocol. So the recent protocol is police. Police is protect. Protect means, again, rest. Then optimal loading. Optimal loading, see, previous concept was to give rest for 3-4 days. Now we are not doing like that. I mean, especially for level 1, I mean, type 1 ligament injuries, you don't have to give rest for too many days. So that is like optimal loading. You start loading physio. This is very important for physio. You start loading, that is optimal loading, OL, and then ice, compression, elevation. This is what stands for police. again, it's a matter of common sense, as I said. So use your common sense whenever applicable and perform the best. Try to avoid these life-threatening emergencies. That is the one thing which the rest of the things we can manage. Even if you do something wrong, it's still okay. But life-threatening emergencies, you have to find out, you have to detect at the right time and prevent further progression. I think that answered your question, Mr. Yeah.
Thank you. Cool. So is there anything else? So Miss Michelle, it is up to you. Shall we end the
Hi,
session?
Doctor. I think there is a question from Hitet Zayar. Dr. Matthew, if you can browse the chat box, please.
Splendors, webinar spin person low back with radiculopathy with symptoms is made sure healthy. This initially had small bony defects at the anterior edge of the vertebral body. This is more structure. See, now this question is purely technical. I mean, I have to review the scans because I cannot comment on this question because it is very medical and technical. I have to go through all the images to give a treatment advice. Maybe you can, if you are able to share the images, then I can give a better idea. So I think I'm sorry, Mr. Sire. I don't think this is including in the scope of this discussion. I mean, current discussion, because it's very technical.
Another question, Doctor, from Mr. Muhammad Lazuni.
Is this? Is you considering the word range of injuries in the limited literature, like such standardized protocol? Yes, such a protocol, negative impact on injuries. Yes. Yes. This is very welcoming, Mr. Muhammad, and thank you so much for this input. Yeah, even I have also, I mean, I've been trying to form a group so that we can later on, I mean, under Professor Jalil, because we are planning to implement that so that we can have a uniform protocol, a uniform framework for the injury risk management across all the different sports. This is actually very welcoming. And if there are more people who can be part of that group and we can delegate our work and we can formulate a uniform protocol under the aegis of, under the banner of APC, and Professor Jalil can take the lead and can guide us further. So it is very important. I mean, it is a very welcoming message. We will look into it. Dr. Shah, we have to look into it. I mean, it's a very good suggestion.
Yeah.
Yeah. How do we assess para-athletes? Professor Alston has asked one question. How do we assess para-athletes with intellectual impairment as the standard diagnostic tool SCAT6 might not be applicable? Yeah, see, SCAT6 is especially for, I mean, assessing and ruling out a concussion, a major head injury happening while games. So that is not the thing for an intellectual impairment, because that is different. This is especially trauma related. I mean, you have to find out what's going on on the field and try to get the best treatment for the athletes so that they can be managed without a life-threatening complication. So we cannot, I mean, there is no scope for checking the intellectual impairment in SCAT6. How do I get the certificate? Michelle, I think they have already answered. There is a 10 questionnaire. I mean, you can, this simple questions we have designed. It's very simple, very basic. You just go through the questions. It's not like hi-fi. Anyone can answer. It's not for doctors or physios. Athletes also can answer. You will get all your certificates. It's very simple, basic question. The topics which we have already discussed, like AD, exertional hypothermia, basic mechanism. This is what are there in the question, so don't worry about that. Obaid has already posted the questions there, so please try to fill it and try to understand. It's not about filling the questionnaire. You should understand what we tried to communicate with you. This is about building a community with good knowledge. This is for all the Asian countries, so that for a clean sport, for a better sports, for a healthy sports, This is just to share the knowledge. So that is the underlying emotion for our seminar and presentation. So just get that emotion. You all will be doing great. Thank you so much.
So as we see here, if you want to get the certificate and answer the questions of the seminar that Dr. Matthew prepared, that you can go to the link that the APC webinar question is on the chat box. And please note that the deadline of the feedback is 21st August. I mean, Friday, I think. And the next webinar, Miss Michelle, I think it is next 2 weeks. Am I right? Miss Michelle?
I think the next is anti-doping. Miss Michelle?
Yeah,
Hello?
the next is anti-doping. Is it, I think it is 2 or 3 weeks later till now. Please be informed.
No, doctor, the next webinar is scheduled on 26 next week. So after this webinar session, we will be circulating the link to do the registration. So we invite you everyone
So
to
the
attend
Wednesday 26th.
Wednesday next week. The topic is regarding the anti-doping results management and TUE and related medical protocols for the upcoming Asian Para Games.
Thank you. Is there anything left, Miss Michelle?
Can I have a last question, please?
Yes.
Okay. Hello?
Yes,
Dr.
sir. Please.
Matthew.
Yes,
Yes.
doctor.
Yes.
Thank you so much, doctor, for your seminar. So, could you please develop a comprehensive sport-specific injury prevention protocol for each Paralympic athlete's discipline, and you can send it to all the MPCs in the Asia Sports Paralympic.
Yes, sir. Actually, it's I mean, this is already in the pipeline. We were discussing this in our APC meetings. And yes, I mean, it's a very good suggestion. It's a very welcoming suggestion. And it's of top priority right now because each discipline, each sport is different. I mean, the injuries are different for each sport. Like I told about the concussion, one sport is like having wrist injuries, one is having shoulder injuries. So you are absolutely right. Every sport has different injuries. So if you have a guideline, it will be easy for the coaches and for the athletes and for the doctors also to check. If you are with one particular discipline, then you have to worry about these type of injuries. So absolutely, I totally agree with your suggestion. And thank you for that valuable suggestions. We'll be working on it.
Thank you so much. Thank you, doctor. Thank you.
Thank you. Dr. Shahab, I think it's almost.
I think it's enough. If you
It's enough.
have any other questions, you can ask the question on the apc.webinar and of Dr. Matthew. Is it possible to finish the session, Miss Michelle?
If there are any more questions, and if Dr. Jalil is here, doctor? No.
Dr. Jalil is not here.
Okay, then I think this is the end of the session. Thank you everyone for joining today's webinar. We are looking forward to seeing you again next week for the upcoming webinar session. This is the link to download the presentation, and yeah, thank you everyone, and see you all again next week. Bye-bye.
Bye-bye.
Thank you.
Thank you.
Asian Paralympic Committee. Thank you, MPCs. Thank you, Dr. Matthew. Have a good time.
Bye-bye.
Thank you, doctors.
Thank you. Bye-bye.
Thank you very much.
Thank you so